Hello guys, I'm Dr. Rahil Gohar and today we are going to discuss about the second part of my video, which is how to identify different pathologies on CT scan brain plane. We have already discussed in part 1 of my video how to identify normal landmarks, normal anatomical structures on CT scan brain plane, and now we are moving towards our second part of our video, in which we are going to identify the different pathologies on CT scan brain plane. So let's begin. Let me first of all change the pointer and let's begin. So this is again about the orientation of the CT scan brain plane, which we have already discussed. Starting from here, this is the base of the skull, and then we are moving, as we are moving to the right side, we are moving towards the vertex of the skull. So here again you can see these are the maxillary sinus, this is the nasal area, and then posteriorly we have got the medulla oblongata and the cerebellum. And as we move upwards, you can see again medulla oblongata and the cerebellum, and as we move upward, you can see this area which is slightly circular. This one is the pons. Posteriorly we have got the medulla, we have got the fourth ventricle, and then the cerebellum. This here you can see the eyes, the nasal area. These are the petrous bones. These are the laser wings of the sphenoid. So this is the middle fossa, and this one is the posterior fossa. And as we move upward, you can see that heart-shaped structure here. This one is the midbrain, and clearly you can see a dot here. This dot is the basilar artery. These are the sylvian fissures. This is interhemispheric fissure. These are the frontal lobes. These are the temporal lobes, right part of the temporal lobe. These are the parietal lobe and the occipital lobe. And in the center you can see, because the tent was like this, it was not a straight structure, but the tent was like this. So this structure here is the cerebellum, and as we move upward, you can see the third ventricle, the frontal horns of the lateral ventricles. This is the pineal calcification of the pineal gland. These are the occipital horns. In the occipital horns again you can see these are the choroid plexus, and this is the calcification of the choroid plexus. Again this is the sylvian fissure, and as we move forward you can see all the things. Okay, now after the orientation, which we have already discussed in the previous part of our video, we are moving forward now. So I have already discussed about different densities, and when I was discussing about the different densities previously in part 1 of my video, I just discussed about the normal structures which appear isodense, which appear hyper or hypodense. Now as we are talking about the pathologies, so which are the pathologies which appear hyperdense on CT scan, means white as compared to the brain parenchyma. Which are the pathologies which appear hypodense, means black as compared to the brain parenchyma, and which are isodense, means similar to the brain parenchyma, means it will appear as gray. So all the acute blood, whether it is trauma after the traumatic injury or it is after spontaneous hemorrhage, all the acute blood appears white, hypertense as compared to the brain parenchyma. All the bony tumors, all those tumors which have got the calcifications like the meningiomas, oligodendrogliomas, and and there are some other tumors which have the specific characteristic that they appear hypertense on CT scan brain plane, which includes the choroid cyst and again the meningiomas. Meningiomas can also appear isodense as well. Then there are hypodense lesions. Most of the tumors which we will see, they will appear hypodense to the brain parenchyma, and most of these include the gliomas. Then there are different cysts like the arachnoid cyst. The arachnoid cyst appears similar to CSF. It is usually hypodense as compared to the brain parenchyma. Then the epidermoid cyst, all those abscesses, infarcts, ischemias, and chronic blood. Then the isodense, there are some tumors, 30 to 40% of the meningiomas they appear isodense. Many gliomas can appear isodense as well. And then we have got the subacute hematoma. So subacute hematoma will appear isodense. So here I want to tell you that acute blood is the blood uh, which is present within, which presents within 3 days of the injury or 3 days of the spontaneous hemorrhage, and it will appear hypertense on the CT scan. And as the time passes, it starts to appear isodense to the brain parenchyma, which is known as the subacute hematoma. And after the 3 weeks period time, it will convert, or it will appear as hypodense to the brain parenchyma, which is known as the clotting blood. Again, which I have already discussed, acute blood occurs before the fourth day. Means during the initial 3 days, the blood will appear as hypertension to the brain parenchyma, and it is known as acute blood. After 4 days and up to the 21 days, usually the blood appears as isolated to the brain parenchyma, and it is known as the subacute blood. It means it will appear as grey on the CT scan brain plane. And finally, after the 21 days, it will appear as black and also known as hypodensity on CT scan brain plane. As you can see here, here we have a subdural hematoma, which I will discuss later. How can we identify the subdural hematomas? So it is appearing, it is subdural hematoma. It is appearing hyperdense as compared to the brain parenchyma, as you can see. So this is acute blood. Then it is, this is the hematoma, and it is appearing isolated to the brain parenchyma. So this is known as the subacute blood. And then finally it is appearing brain, as compared to the brain parenchyma, it is appearing blacker. So it is hypotense and it is a chronic blood. Then again you can see acute, subacute and chronic blood. Now moving forward, all those pathologies which we are going to discuss. So we are going to identify different traumatic hematomas like the extradural hematoma, you must have heard about it, subdural hematoma, contusions, subarachnoid hemorrhages, traumatic intraventricular bleeds or spontaneous intraventricular bleeds, and intraparenchymal bleeds, fractures, pneumocranium, foreign bodies, hydrocephalus, how to identify hydrocephalus in CT scan brain plane, and how to identify different infarctions, ischemia, and different space occupying lesions like tumors, abscess, etc. So let's move forward, and this part of the CT scan brain is the most important one, because in the field, when you are working as a doctor, as a neurosurgeon, and you are in the emergency area and you see a CT scan brain plane, you are going to see some pathology in it, and that's we are going to discuss now. So let's begin. So before moving towards the CT scan, we have to see some of the things, some of the pictures, colorful pictures, so this is, we can understand it better. So again, you can see this is the brain, these are the gyri, and in between we have the sulci. Then this layer is known, this one is the pia mater. There are 3 layers of the dura on the brain surface. So this is the pia mater, this one is the arachnoid mater, and then finally we have a dura mater, and dura mater has 2 layers. One is the meningeal dura mater and one is the periosteal dura mater. So these are the 3 layers of the dura, and then finally we have the skull and the scalp. So when so first of all we are going to discuss about the epidural hematomas and the subdural hematomas. So what is epidural hematoma? If it is outside the dura mater, if it is outside the dura mater, then it is known as epidural or extradural hematoma. And if it is below the dura and above the arachnoid mater, it is known as a subdural hematoma. Okay, so this is the difference between them. Now again you can see here that there is a fracture here in the skull, and we have got a collection beneath the bone and above the dura mater, and this is known as the epidural hematoma. Now here again you can see that the dura is adherent to the bone and the blood is below, or the collection is below the dura mater, and this is known as the subdural hematoma. So again now, as you can see here, extradural hematoma, this is the CT scan brain plane, and as you can see, we can see a hyperdense area on the right parietal frontoparietal region. So you can see and you can appreciate that it is hyperdense. So again, if the patient has come to us with trauma and we see the CT scan and you see a hyperdense area inside the brain, as you can see here, so obviously it is acute blood. Now we have to identify what type of acute blood this is. So I am saying this is EDH, extradural hematoma. So how can I say that? So there must be some features to it which we can apply on the CT scan brain plane, and we can say this is epidural hematoma. So again, as you can see that there are these 4 features usually which we can apply to the epidural hematoma. So it will appear hyperdense. We all know acute blood is hyperdense. Then secondly, it will appear as biconvex. So layman chapter biconvex, you can see this hematoma is biconvex. It is convex here, and because of the bone on the other side, it is convex here as well. It will not cross the suture line. Why? Because the dura mater is adherent to the suture lines. So for example, if here is the coronal suture, so the EDH will not cross the coronal suture. This is a very important feature of the epidural hematoma, that they do not usually cross the suture lines. So that is a very important feature to differentiate between the epidural hematoma from the subdural hematoma. And again, it cannot cross the midline. Why? We all know that there are three layers of the dura mater: pia, then arachnoid, and then the dura mater, the meningeal layer and the periosteal layer. Now the thing is that when it comes into the midline, it goes into the interhemispheric fissure. So epidural hematoma is above the dura mater, so it can easily cross the midline. It cannot usually cross the sutures line, but because the dura goes inside like this, so it can easily cross the midline. So this is a very important point about the epidural hematomas, that they can cross the midline where interhemispheric fissure or interhemispheric area is, or the fourth cerebri is. Okay. Now moving forward, as I have already told you that EDH does not cross the suture lines. So you can see this is the coronal suture, this is the parieto-occipital suture, and here you can see it usually does not cross the suture line. But so there are two extradural hematomas. One is this one, and one is this one. And as the dura is adherent on the suture line, so you can easily see that it is forming a biconvexity here and here as well. So there are two EDH in the parietal and occipital area. Now again, as I have already told you that the EDH can cross the midline, so you can see over the interhemispheric fissure it is crossing the midline. Okay, so this is EDH because it is biconvex in nature, it is hyperdense, and it can cross the midline. So this is also EDH as well. Swirl sign. This is one of the features which you will be able to see in acute hematomas after traumatic injuries. It is usually seen in the EDH. As you can see, mostly the EDH is hyperdense, but in the center you can see the hypodensity here. Again in this picture you can see the hypodensity here as well as here. Again here and again here. Swirl sign is actually representing the active bleeding within the clotted hematoma. So why the hematomas appear white on CT scan brain plane? Because the hematoma gets clotted, and all the hemoglobin inside it has got the heme and iron, so it is blocking the X-rays, and that's why it is appearing hyperdense. But this central area is actively bleeding right now, and it has not clotted yet. That's why it is appearing hypodense as compared to the clotted blood. So this is known as the swirl sign. And if you see a swirl sign, it can be an indication, or it can be it can be indicating that there is active bleeding going on, and you have to go and immediately operate on this patient. So that's a very important sign which you can see on the CT scan brain. Now, whenever a patient has come to you in the emergency department, and you as a neurosurgeon is seeing a patient, and you see a CT scan and you see EDH. Now, not all EDH or hematomas needs to be operated. So we have to see which hematomas we need to operate. So there are some indications. If the patient GCS is down and there is a EDH, you have to go and operate it. If there is hematoma thickness is greater than 1.5 centimeter, then you are going to go and operate it. If there is midline shift of more than 5 mm, then you are going to go and operate it. And finally, if the volume of the hematoma is more than 30 ml, then you are going to go and operate it usually in the supratentorial compartment. Because in the infratentorial compartment the indications are different, the volume of the hematoma is different, which needs to be operated. So how can we calculate what is the amount of hematoma? So this is a simple formula: A, B, C. So A is the length, then width and height. So you are going to multiply all these things and finally divide it by 2. Okay, and length and width you can see on the axial scans, and height you have to see the coronal sections, but not it is not usually we only get the axial sections. So in the axial sections we can also calculate the height as well. I am going to tell you this. So in the picture you can see, let me move it. So in the picture, in this axial section, you can see this A is the length, this is the width, and then finally on the coronal section you can see the height. So usually on the CT scan you can see the markings. I can show you, let me show you. in this orientation area you can see these markings here. These are actually representing 1 centimeter. This one box is 1 centimeter, then 2 centimeter, 3 centimeter, 4 and 5. So with this scale you are going to measure the length, height and width of the hematoma. So let's see. So here, for example, if the A is 6 centimeter, B is 3 centimeter and C is 7 centimeter, you are going to multiply all of these things and you get 126. You divide it by 2 and you get 68 ml. Okay. And if the volume of the ED is 30 ml or thickness of the hematoma is 1.5 centimeter, then the patient needs surgery irrespective of the GCS of the patient. This is very, very important. Now, again here you can see we are going to calculate the hematoma thickness hematoma. So this is very, very important. Now here because we are calculating the hematoma on the axial sections only, we are not using the coronal sections now, because in most of the sectors like the setup we are working, usually when a patient comes from the emergency department, they only get the axial sections of the CT scan. We only get the axial sections of the CT scan, so we calculate it using the axial sections only. So the formula is slightly different. So here you can see A is again the length, then B is the width, and then N is the number of slices in which the hematoma is appearing, and finally what is the thickness of these sections. Either they will be of 0.5 mm, 0.5 centimeter means 5 mm, or they will be of 1 centimeter or 10 mm in thickness. So if it is 10 mm, then there is no problem, you are going to write 1 centimeter 1 and it will not affect your result. But if it is 5 mm size, then you are going to write here 0.5 because we are going to measure in centimeters. So A into B into N means number of slices, thickness divided by 2 simply. So what we are going to do, if the A is 5 centimeter and B is 2 centimeter, so it is 10 centimeter, number of slices are 7 and thickness is 1 centimeter here in this picture. So we are going to multiply all these things and we will get 70. We will divide finally it by 2 and we will get 35 ml. So this is simply the amount of volume which needs to be operated irrespective of the GCS. Okay. Now the subdural hematomas. So again, the subdural hematoma is a hematoma which is in between the arachnoid matter and the dura mater. It is below the dura mater. So as it is below the dura mater, so its features are different from the epidural hematomas, and we need to identify it because the management can be different for subdural hematomas. Okay. So here again, it will have a hyperdense like the EDH. It will have a concave shape or crescent shape or banana shape, as you can see here. It is not biconvex like the EDH. So this is the first difference between the two. Secondly, it will cross the sutures line. The EDH was not crossing the sutures line. Why it is crossing the suture line? Because it is below the dura, and dura is adherent with the sutures line, but this hematoma is below the dura and it is in the subdural space, so it will go according to the contour of the brain. While the epidural hematoma was restricted at the points where the dura was adherent with the suture line. So that's the difference between the subdural and epidural hematoma. Then finally it cannot cross the midline. Why? Now the epidural hematoma was above the dura mater. So when the dura were going in the midline, EDH was able to cross over it, but the dura is now, but the subdural hematoma is below the dura. So when the dura goes like this in between the two hemispheres, the subdural hematoma also goes like this in between the interhemispheric area. So it will never cross the midline. These two are very important differences between the EDH and the SDH. Again, you can see there are different types of subdural hematomas. It can be acute, it can be subacute, it can be chronic. Usually EDH are acute, and when they come to us, we usually operate on them. Or if they are very small in size and the patient GCS is 15 by 15 and there is no deficit, then we can observe them. But usually we see acute hematomas when we are talking about the EDH. Now, when we are talking about the subdural hematoma can come in RTS. For example, if a patient has come to us with a road traffic accident, we can find the subdural hematoma. But subdural hematoma can also appear in older age groups. Like for example, if a patient is 70 years old, he is taking anti-epileptics or the antiplatelets, and he just has had a small concussion, a small trauma. He fell on the ground, and he did not consider it a very big deal. Then after a few weeks or after a few months, there is small collection from the veins, and this collection is going to cause significant pressure with the passage of time. This there is one more thing, one more difference between the acute and EDH and subdural hematoma, and that is the epidural hematoma is usually from the arterial bleeding. And I need to tell you one thing, that there is a part of skull which is known as the pterion. That pterion is the part which is the weakest part of the skull, and whenever there is blow to the pterion, below the pterion there is a branch of middle meningeal artery which is known as the anterior branch. It gets ruptured and it results in the formation of the extradural hematoma usually. So usually EDH is from the arterial bleed, but subdural hematomas are usually from the venous bleeding. So, because the veins and the vessels are running from the surface of the brain into the outside, so it is crossing the these layers, and whenever there is rupture of these veins, there is collection of subdural hematoma. And in older age groups, because there is atrophy, so these veins are slightly stretched, and also they are on anticoagulants. So what happens whenever there is small trauma or minimal trauma, or not means usually in older age groups with the minimal trauma, these veins get ruptured, and because there is atrophy of the brain, there is much space in the older age group patients. So initially there are no symptoms, but with the passage of time, as the hematoma grows in size, it produces some pressure on the brain, and the patient comes to us with altered sensorium, seizures, one-sided weakness, and when we perform the CT scan brain plane, we see this cornucular. So again you can see this is a CT scan brain plane axial sections, and you can see a hypodensity on the left side, and you can see the sulci and gyri are not visible here, but they are visible here. So it means it is producing some pressure on the left side. This is known as the chronic subdural hematoma. Here you can see there is something here, and it is pressing on the left side, and you can see there is some effacement of the lateral ventricles as well on the left side. So this is appearing isodense to the brain parenchyma, and it is known as the subacute hematoma. Then finally, as you can see here, there are bilaterally you can see crescent shape. Um, the posterior or the posterior part you can see is hyperdense, and the anterior part is hypodense. And again here you can see the posterior part is hyperdense and the interior part is hypodense. So this is known as acute on chronic blood. For example, there is a patient who has got some chronic blood inside his brain, and there is no problem, it is not causing any problem, and suddenly he gets a RTA or some other trauma, and that there is bleeding going on inside the chronic blood, and because the chronic blood is already there, so this acute bleeding now will produce sudden pressure on the brain, and the patient will come to us. We will perform the CT scan and we will see this picture where we will say that there is acute bleeding inside the chronic subdural hematoma. So this is known as acute and chronic subdural hematoma. Now there are some extensions of subdural hematoma as well. As I have already told you, there the dura when comes in the midline, it divides the hemispheres into two, right and left, and this is known as the interhemispheric falx cerebri, and the fissure is known as the interhemispheric fissure. So the subdural hematoma is below the durameter. What happens? The blood goes below the durameter and it comes in between the interhemispheric area, which is known as the interhemispheric bleed or falx bleed, which is actually a subdural hematoma. So again, you can see on the left side there is a subdural hematoma. It goes into the midline, and then it comes into the interhemispheric area. In the same way, there is one more structure like the falx cerebri, which is known as the tentorium cerebelli. The tentorium cerebelli is actually dividing the supratentorial compartment from the infratentorial compartment, as I have already explained in part 1 of my video. This is again a durameter fold which goes like this inside, and it divides the supratentorial cavity, intracranial cavity into supratentorial and infratentorial compartment. So the subdural hematoma can extend into this area as well. So this is known as the tentorial extension of the subdural hematoma. As you can see here, this is a subdural hematoma and it is extending into the tentorium cerebelli. Now, I have already discussed about the differences between the extradural and subdural hematoma. Again, I am going to discuss it. The epidural hematoma is bounded by the sutures line. So this is the coronal suture, and it is bounded by the coronal suture. It is biconvex, lemon shaped, and here the subdural hematoma is crescent shaped, banana shaped, and here is the coronal suture, and it is crossing the coronal suture. So this is very important. And again, I have already told you that EDH can cross the midline, but subdural hematoma cannot cross the midline. This is one more difference between the two. Also, if pathologically speaking, EDH is usually due to the arterial bleeding, and subdural hematoma is usually due to the venous bleeding. Okay. Again, which I have already explained to you, that EDH does not cross the sutures line, but it can cross the midline because it is above the dura mater. As you can see here, this is the falx cerebri, and above the dura it is crossing the midline. But when we are talking about the SDH, it is below the dura, so it will come here like this, and it will go in the interhemispheric feature. It will follow the falx cerebri, so it will never cross the midline. Okay. Now, how can we identify midline shift? What is midline shift? Midline shift is actually whenever there is some space. There is one thing which you need to understand. That that there is skull, and intracranial cavity is inside a box, and this box is stiff. It is not stretchable. It is not elastic, and there are mainly three components inside the intracranial cavity. One is brain, second is the CSF, and third is the blood. And whenever fourth thing comes inside the brain, it is known as the space occupying region. It can be abscess, it can be a tumor, it can be a hematoma, secondary to spontaneous cause or secondary to trauma. But whenever it will come inside, the fourth thing will come inside. It will compress the already means it will compress all the structure which are already present in the intracranial cavity. So it will increase the intracranial pressure, which is in short form we call it ICP. So here you can see when there is subdural hematoma, as you can see here, it is causing pressure on the right side of the brain. So what it is causing? It is causing the ventricles to shift to the left side. So this is known as the midline shift. The midline structures are shifting to one side because of the hematoma on the other side. So how can we calculate the midline shift? Actually, what is significant midline shift? Significant midline shift is if the midline shift is more than 5 mm. Means it is producing significant pressure, and we have to remove the cause which is causing the rise in the pressure usually. So how can we calculate the midline shift? Actually, as you can see here, we draw a line from the crista galli, which is anteriorly present, up to the inion part of the occipital bone, and this line is actually representing the midline. And then the ventricles, which are the lateral ventricles in the midline. Lateral ventricles has a septum in between, which is dividing the two lateral ventricles from each other. This septum pellucidum is usually in the midline, and with this with its help we are going to calculate the midline shift. So what we do, we draw a line from the crista galli up to the inion in occipital protuberance, and then we draw a line from the center of the septum pellucidum, which we can identify with the help of the two lateral ventricles, and then we calculate the distance from the midline up to this septum pellucidum. And if it is greater than 5 mm, it is considered a significant midline shift. Here you can see again we have drawn a line, and this is the septum pellucidum, and you can see that it is nearly 15 mm. It is very significant. One thing I missed is when we are talking about the subdural hematoma, when we were talking about the epidural hematoma, we discussed about the indications of surgery, and that either it will be the 1.5 mm thickness, centimeter thickness, or either there is decrease in GCS, or the volume of the hematoma is 30 ml. When it comes to the subdural hematoma, we only take the thickness of 1 centimeter. If it is 1 centimeter thick, we are going to operate it. The patient's GCS is low, we are going to operate it. If it is causing midline shift of greater than 5 mm, we are going to operate it. So this is very important. Now contusions. Contusions are, again, what are the contusions? Contusions are some bruises which are present on the cortical surface secondary to trauma. Now these contusions are usually at areas where the parenchyma is near the bony surface, bony protrusions, and it is usually secondary to trauma, and it is intraparenchymal. There are small vessels which gets disrupted which gets ruptured due to trauma, and these causes the contusions. Now, how they will appear on the CT scan and how can we identify the contusions? First of all, it will be heterogeneous. Now, up till now, we have discussed the epidural hematoma, we have discussed the subdural hematoma. They were appearing hyperdense. They were appearing white as compared to the brain parenchyma. But the contusions, and they were outside the brain parenchyma. They were in the dural layers. But the confusion is, first of all, it is inside the parenchyma. Secondly, it is heterogeneous. Some part of it is white, hyperdense, and some part of it is black, hypodense. Here you can see that some part of the confusion is white and some part of the confusion is black, because the bleeding part is white, and because there is rupture of these small vessels, it is causing surrounding edema as well as surrounding ischemic areas as well. So it will appear as heterogeneous, as you can see here. Again, there is a small confusion here. It is white as well as black. So this is a confusion as well. When we are talking about the contusions, again, what are the indications of operating a contusion? When there is a drop in the GCS, when there is a midline shift of greater than 5 mm again, and when we are talking about a contusion, the volume should be greater than 50 ml, or it should be 50 ml. When we are talking about the posterior fossa, now the 50 ml mark is for the supratemporal compartment, means if it is in the frontal lobe, in the parietal lobe, in the occipital lobe. But when we are talking about the posterior fossa in the cerebellar area, if it is 30 ml, we are going to operate it. Okay. Now, after discussing all about the trauma, we have come to a part where we are going to discuss about the spontaneous intraparenchymal hemorrhages, bleeding. For example, if a patient has hypertension and suddenly his BP is 220 by 120 and he gets paralyzed on one side, he becomes unconscious. So we perform a CT scan. There is some acute blood inside the brain parenchyma, and this is known as the intraparenchymal bleed, spontaneous intraparenchymal bleed. Usually, it is not because of trauma. It happens spontaneously after some patient blood pressure rise, or maybe there is aneurysm, maybe there is AVM, means arteriovenous malformations, which is causing the bleed. So again, you can see there is no history of trauma. It is not near the bony surfaces. It is inside. Usually they are deep inside the basal ganglia. Most common location is the basal ganglia, thalamus, posterior fossa. Again, you can see in the axial section there is intraparenchymal acute blood in the area of the lentiform nucleus. Here you can see it is in the right side, on the right side, because it's the third ventricle. So on the right side of the third ventricle there is thalamus. Then you can see in the brain stem there is a bleed. In the posterior fossa and the cerebellar area there is a bleed. So these all are acute bloods, and they are spontaneous blood, because these are the common locations for these bloods. So simply they will appear hypertense and they will be spontaneous in nature. Subarachnoid hemorrhage. Now the subarachnoid hemorrhage is a hemorrhage which is in where the subarachnoid hemorrhage is. Subarachnoid space is the part where it is in between the pia mater and the arachnoid mater, where the CSF is, where our major vessels are. So subarachnoid hemorrhage is a bleed which is present in the CSF spaces, so in between the sulci, inside the sulci. These are the inside the cisterns. So if the blood is present in the sulci area, in the cisternal area, it is known as the subarachnoid hemorrhage. Subarachnoid hemorrhage can be secondary to trauma, or it can be spontaneous as well. If it is spontaneous, it can be due to aneurysm, it can be due to AVM, and many more causes. So how will it appear? It will appear hyperdense again, because the blood on the CT scan appears hyperdense. Now, secondly, if it is in the sulcal area, it will appear as finger-like projections. As you can see, these are finger-like projections. So it will appear like this. And secondly, if it is in the cisternal area, it can appear, it will be in the, first of all, in the sulcal area, in the hemispheric area, in the fissures area, and if it is in the basal systems, it will appear like this, star shape, as you can see here. And again, in the Sylvian fissure, you can see hemorrhage. So this is known as the subarachnoid hemorrhage. So it is in the subarachnoid spaces. Now, intraventricular bleed, if this bleed is inside the ventricular area, in the lateral ventricles, in the third ventricle, in the fourth ventricle, it is known as the intraventricular bleed. Intraventricular bleed can be due to trauma, it can be due to again AVMs, it can be due to the aneurysms, it can be an extension of some part of the hematoma which is inside the intraparenchymal area and it is coming to the intraventricular area. So again you can see on the axial sections, this is the between the third ventricle, these are the in the lateral ventricles, as you can see here and here. And if it is producing significant hydrocephalus, we are going to intervene in this patient as well. Now, how are we going to identify different fractures? We have already seen in the previous sections how the sutures appear in the CT scan brain plane. Now, usually what happens that the skull bones are like this. We have outer table, inner table, and in between we have the diploid bone. And where these two bones are meeting, for example, two parietal bones are meeting at the sagittal suture. So these sutures appear like this, zigzag type. And this is very very important. It should be remembered that these cortical bones, these outer and inner table are meeting at the suture area. So you can see there is a cortical bone which is covering the suture area. But when there is fracture, this cortical bone will not be present and the fracture line is usually straight. So here again you can see the sutures. The suture, this is the inner, this is the outer table, inner table, and the cortical bone is at the suture line as well, as you can see, and it is appearing zigzag. Again you can see here. Now when we are talking about the fractures, as you can see, fracture is usually straight and there is no cortical bone at the fracture side. Again you can see here, this is a cortical bone here, this is a cortical bone here, in between we have the diploid bone, but at the fracture side there is no cortical bone. Again here you can see that there is no cortical bone at the fracture side, and also it is straight, it is straight. So here's how you can identify different fractures. And again, I have already explained to you in the first part of my video that there are two types of windows: parenchymal window, in which we see all those hematomas which we have already discussed, and in the bone window, where we just obscure the parenchymal area and we see the fractures, we see the pneumocranium as well. Now, what is depressed fracture? Depressed fracture, as you can see, the name also demonstrates, if the bone is going inside the intracranial cavity, it is known as the depressed fracture. And sometimes we have to operate the fractures, and sometimes we just observe the fractures and the patient gets better with the passage of time. So again you can see there is a trauma, there is subgaleal hematoma, means the hematoma inside the scalp, and then there is this fracture. You can see it is going inside the intracranial cavity. Again you can see it is a bone window. In the parenchymal window you can see a bone chip is going inside the intraparenchymal area. It has ruptured the dura and it is going intraparenchymal, so we have to operate this patient. Now this is known as the ping pong fracture. In patients who are less than 3 years old, usually who are 1 year, less than 1 year old, they get this type of fracture because their bone is elastic. So it does not get fractured, but it goes inside like a plastic ball, like a plastic ball. And usually we do not need to operate on this patient. With the passage of time, it gets to its means it usually gets to normal with the passage of time. These are known as the ping pong type of fracture. Now, what are the indications in which we are going to operate the depressed fracture? If there is a significant, if the fracture is more than, if the fracture is inside the intracranial cavity and it is more than the thickness of the skull bone, first. Secondly, if it is causing some kind of parenchymal bleed, EDH, SDH, or maybe contusion, if there is CSF leak, if there is open wound and a fracture like this, it is going inside the parenchymal area, so it is going to produce sweats. So we have to remove and we have to repair this type of fractures. Now the pneumocranium. Pneumocranium is also very important. Pneumocranium is what is pneumocranium? Pneumocranium is the accumulation of the air inside the intracranial cavity. It can be outside that. It can be outside the dura, or it can be intraparenchymal as well. So again you can see, and it is usually associated with the fractures, and we can easily see this pneumocranium on parenchymal as well as on the bony window. So here you can see there is a fracture and air is getting accumulated here in the parietal area. So here you can see that there is a pneumocranium, air anteriorly in the frontal area, bifrontal area. Now this is very important. Here we can see that there is a pneumocranium and it is producing a sign here. It is known as the Mount Fuji sign. You can see two mountains here. So this is known as the Mount Fuji sign. This is important because usually we manage the pneumocranium uh, by conservatively we apply high flow oxygen and usually the pneumocranium gets resolved. But sometimes a patient comes to us with the tension pneumocranium. Means there is a tension inside the and it is producing mass effect. It is raising the ICP. Like here you can see in the Mount Fuji sign, there is compression of both the frontal lobes. So in this case we have to go and intervene and decompress the brain. Okay. Moving forward, foreign bodies. Um, Many a times you see a gunshot patient and there is a bullet which is present inside the intracranial cavity. So how it will appear? So you can see it will appear like this. You can see different radiations, and this is like an artifact. It distorts the image, and this is a characteristic feature of the metallic foreign bodies, as you can see here on the parenchymal window as well as on the bony window. Then again, sometimes we introduce the foreign bodies ourselves. Means, for example, if the patient is come to us with hydrocephalus and we are going to produce insert a shunt, so you can see the shunt on the CT scan brain plane. Okay, as you can see here, this is EVD, extraventricular drain, maybe most likely. But here we can see the shunt shadow as well and chamber of the shunt as well. Now moving forward, hydrocephalus. So after discussing all the hematomas, traumatic as well as the spontaneous hematomas, we are going to discuss about hydrocephalus. This is very important. So what is hydrocephalus? It is abnormal accumulation of CSF inside the ventricles, and it is enlarging the ventricles. It is producing the signs and symptoms of the raised ICP, and we are going to go and treat it. Now there are two types of hydrocephalus. It can be acute, it can be chronic. If it is chronic, we can give it time, and we can see our options. What do we want to do? Do we want to do the shunt? Do we want to do endoscopic third ventriculostomy or any other option? But when it comes to acute hydrocephalus, we have to treat it emergently, because if we don't treat it emergently, the patient can die as well. So how can we identify on the CT scan brain plan if it is other than the clinical picture of the patient? How can we identify on the CT scan brain plan whether it is acute hydrocephalus or chronic hydrocephalus? And other than acute or chronic hydrocephalus, how can we identify if it is hydrocephalus or not? So here are some features. So first of all, we have seen the normal anatomy, we have seen all the CT scans, and you all know how the ventricles usually appear. So first of all, whenever there is ballooning of the ventricle, as you can see, the third ventricle is ballooned up, the frontal horns, the occipital horns have ballooned up, and also the temporal horns, they have ballooned up. So first thing is, if there is ballooning of the ventricles, it is obviously hydrocephalus. Now if usually the temporal horns are not visible, and if they are visible, they are less than 2 mm in size, and if the temporal horns are greater than 2 mm in size, then we call it hydrocephalus. As you can see, it is these temporal horns are very enlarged. Now there is one very important ratio which is known as the Evans ratio. If it is greater than 0.3 or 30%, it is we label it as hydrocephalus. I am going to show you how can we measure it. Now how to identify the acute component of the hydrocephalus? There are some features. First thing is, as you can see in these pictures, the sulci and gyri are not visible here. So it means this hydrocephalus is causing pressure on the brain, and it is effacing the sulci. This is a feature of acute hydrocephalus. Secondly, you cannot see the cisterns clearly, so there is effacement of cisterns as well. This is also a feature of acute hydrocephalus. Thirdly, you can see this blackish area around the ventricles. This is known as the transependymal seepage. So this is also representing the acute component of the hydrocephalus. So these features, the effacement of the sulci and gyri, the effacement of the cisterns, the appearance of the transependymal seepage, and again the clinical picture of the patient will come to you with a headache, with vomiting, and altered level of consciousness, maybe seizures as well. So these are all the features of acute hydrocephalus. Now coming back to the Evans ratio. So this is how we calculate the Evans ratio. We take one slice, extra slice of MRI or CT scan. We take on that slice the biparietal distance and the distance of the frontal horns, and then we divide it, the distance from one frontal horn to other frontal horn with the distance from the parietal to parietal area. So here you can see the ventricle size is divided by the skull size, and you get the Evans ratio. So if it is more than 30% or 0.3, then we call label it as the hydrocephalus. Gray white differentiation, this I have already discussed about it in the first part of my video. So again, when we are talking about the parenchyma, there are two parts of the parenchyma. One means the parenchyma is made of the neurons. We have got the cell bodies and we have got the axons. So the cell bodies and the axons, usually the brain parenchyma is grey, but in this grey we have two types of color. As you can see, the outer part, which is made up of the neurons, is slightly whiter as compared to the inner part, which is made of the axons. This is the corona radiata actually, now where all the axons are coming together. So the axons appear blacker as compared to the neuronal cell bodies, the cortex. This is the cortex. So the cortex is more whiter as compared to the white matter or the axons, and this junction where this distinction is made is known as the gray white differentiation. And this gray white differentiation is important because it gets lost if there is gross rise in ICP and there is gross edema, and it can also get distorted when there is ischemic area. So this differentiation is lost, and there are some tumors in which this differentiation is heightened. So we are going to discuss about these things. How can we, with the help of gray white differentiation, identify whether there is some kind of pathology or not? Okay, let's move forward. So now, how can we identify ischemic infarcts, ischemia on the CT scan brain plane? So there are different methods to identify it. First of all, as I have already told you about the gray white differentiation. So first, gray white differentiation. As you can see here in this picture on the axial section, this is the part where the axons are. This is the part where the cortex is, neuronal cell bodies are, and you can see clearly the differentiation. But here this differentiation is lost. You cannot see the differentiation. All appear black. So this is an area where acute infarct has occurred. So gray white differentiation, if it is lost in the local area, in a particular area, it can indicate that the patient is suffering from infarct. Again, you can see there is the cortex, there is the axonal area. So you can see the gray white differentiation, but again here you can see the gray white differentiation is lost. Actually, if with the passage of time the infarct become more blacker, and it is not a more blacker with the passage of time, because the brain part that was infarcted, it gets resolved from there, and then the CSF start to collect at that point. So that is why it appears more blacker with the passage of time. Again, you can see from this area, you can see with the ischemic infarct, there is no gray white differentiation, and also there is very much edema in this picture. So ischemic infarct usually appear blacker as compared to the brain parenchyma, and there is local loss of gray white differentiation in that area. So one thing to identify the ischemic area, infarcted area, is gray white differentiation, loss of gray white differentiation. Now there is a sign which is known as the hypertensive NCA. Usually when we see the CT scan, we can see both the MCS, and they usually appear slightly hypertense. But if one of the MCS becomes hypertense and the patient has come to you, for example a 70-year-old male patient, he was hypertense, he was diabetic, he has come to you that Dr. Saab, I have got this paralysis on the left side, and you perform a CT scan, you do not see the infarct, but you see this hyperdense MCA. So you make your conclusions that the patient is getting the infarct, and it has not yet appeared on the CT scan brain plane, because usually the infarcts do not appear on the CT scan brain plane in the initial 12 hours. So we have to perform the MRI with DWI images in which we can see the infarct. Then there is a sign which is known as insular ribbon sign. Now here you can see this is the Sylvian fissure, and inside the Sylvian fissure we already know we have one more cortex which is known as the insular cortex. So this insular cortex becomes ischemic, and this area becomes blacker as compared to the normal. As you can see here, this area appears blacker as compared to this one, and also the sulci, gyri here, the differentiation here is lost. So this is known as the insular ribbon sign, which is also representing the acute impact. Now there are different vascular, there are different territories, different vessels which are supplying the different areas of the brain. So the medial part, the medial anterior part of the brain is supplied by the anterior cerebral artery. The lateral part is usually supplied by the middle cerebral artery, and the posterior occipital part is supplied by the posterior cerebral artery. So if we have got the infarct of this area, as you can see, there is a hypodensity in the territory of the MCA. This is known as the MCA infarct as compared to the left side. Then as you can see, there is hypodensity of the anterior part. This is the ACA infarct or anterior cerebral artery infarct. As you can see, this is the infarct of the PCA territory. Now how can we say it is an infarct? I have already told you about the loss of differentiation. I have already told you about the MCA sign, insular ribbon sign. But whenever the infarct occurs in the territory of the vessel. So you have to know the vascular supply of the brain very clearly to know that the infarct has occurred. And infarcts are usually wedge shaped. As you can see here, it is wedge shaped in nature. As you can see, it is wedge shaped because the vessel has got occluded, and the area which was supplied by the artery was in wedge shape. So that wedge shaped area gets infarcted. Now, different space occupying lesions, how can we identify whether it is a space occupying lesion or something else? So as you can see, first of all, how can we identify? There are some features. The space occupying, usually they appear hypodense. Sometimes there can be calcifications in them, like in the oligodendrogliomas. They usually present in the white matter region. Usually I am talking about the gliomas. The gliomas are usually in the white matter region. Then they are associated with edema, vasogenic edema. What is vasogenic edema? Vasogenic edema is a type of edema in which you will see the finger-like projections. Okay, so here I am going to show you. Then usually the high-grade gliomas, they usually show ring enhancement when we give the contrast. So here you can see this is a plain CT scan brain, and there is some hypodensity in the left frontal area, and you can see the finger-like projections here as well. So this finger-like projection is actually vasogenic edema, and we cannot, we can see some hypodense area here. Maybe this is tumor and it is producing the edema, and when we give the contrast, you can see the ring enhancement here. So this is a high-grade glioma. It is producing the significant edema, vasogenic edema. Also, there is effacement of the lateral ventricle, and it's causing the midline shift, slight midline shift as well. So you can see the glioma with and without contrast. So usually gliomas appear hypodense, and they space occupying. Whenever we are talking about the tumors, whenever we are talking about the abscesses, they usually present with vasogenic edema, and they are in the white matter. Now how can we differentiate between the infarct and this space occupying lesion? Simple. Here you can see there is heightening of the gray white differentiation. You can see the cortex is white, and you can see the edema and the tumor is more blacker as compared to the coronal radiata. So there is heightening of the gray white differentiation, which is helping us to differentiate this from the infarct, because the infarct will involve the white as well as the gray matter, and there will be hypodensity in the wedge shape area. There will be no finger-like projection, no vasogenic edema like this. There can be edema, but not like this. Okay. So this is how we can differentiate between the hypodense, tumor, abscess, and the infarct. Okay. Now moving forward with the metastasis. So metastases are usually, first of all, they will also appear hypodense. First of all, there will be vasogenic edema. So how can we differentiate? We usually cannot differentiate on the basis of CT scan whether it is a glioma or the mets, but sometimes we can, because metastases are usually more than one in number. They are usually small, they are circular, and when they give contrast, there is ring enhancement, and it is regular ring enhancement. Okay, so here again you can see also when we are talking about the mets, they are usually at the gray white junction, but they can be anywhere. Okay, so here again you can see there is finger-like projection, there is hypodense area in this one. So this is there is vasogenic edema, there is heightening of the gray white differentiation, and here you can see some lesion. Okay, and it is appearing isodense to the brain glioma. Then when there is another CT scan of the patient, here you can see a ring enhancing lesion. It is producing a significant edema, and also there is heightening of the graphite differentiation. So this is a metastatic lesion. Now moving forward, arachnoid cyst. Arachnoid cyst is actually what happens. There are, as I have already told you, there are three layers of the durameter: pia, arachnoid, and durameter. Sometimes what happens, the arachnoid layer gets split, and there is a formation of the cyst inside the arachnoid matter, and this is known as the arachnoid cyst. As you can see, and usually it is present in the temple area. So you can see, and it appears like CSF. So here you can see in the fourth ventricle, the CSF is appearing black abundant, and the density of the arachnoid cyst is similar to the CSF. So this is arachnoid cyst, and this is an arachnoid cyst in the temple area. Again in the frontal, right in the frontal area, you can see there is a arachnoid cyst, and it is causing effacement of the lateral ventricle and also midline chamber. So arachnoid cyst is appearing like CSF. It is usually symptomatic. We usually just observe the arachnoid cyst. We do not operate it unless and until it is causing some symptoms like fits, like raised ICP. As here you can see, it is causing effacement of the sulci gyra. It is causing effacement of the lateral ventricle. So we can go and operate in this case. Now intracranial abscess. Again, intracranial abscess, they appear hypotense as similar to the other usually tumors, other usual tumors, and it will also have the finger-like projections, means edema, vasogenic edema. So here you can see this is the axial section. There is a hypotense area. It is circular. It is well defined. It has edema, and again on the contrast CT scan you can see the ring enhancing area. There is vasogenic edema. There is heightening of the graphite differentiation. So how can we differentiate it from the glioma, high-grade glioma, from the metastasis? First of all, metastasis. First of all, the gliomas are usually they are present usually in older age patients. Secondly, the gliomas are usually irregular in shape, and the symptoms are usually very rapid, 2 to 3 months period, and they usually do not have fever. Okay, but when we are talking about the abscess, the patient may have some kind of dental procedure some time back. There may be some kind of cardiac abnormality in a child, like because there can be some ear infection few months ago, and now the patient has got intracranial abscess. There was trauma, maybe history of trauma in the frontal area, and the patient has got after some time intracranial abscess. The patient can have fever, and when we will see the CT scan contrast or the MRI contrast, you will see a regular large lesion. It will be ring enhancing, and it will have edema. When we are talking about the glioma, there will be no such features. Means and also there will be no fever. There is no history of trauma, no history of ear infection or dental procedure or some cardiac defect. So these are some differences on the basis of clinical history, and on the basis of the contrast scans. Okay, so this is how we can differentiate between a glioma and an intracranial abscess. So how can we differentiate between tumor versus infarct? I have already discussed these things. As you can see that this is infarct. There is a hypotenuse area in the parieto-occipital ligament. Now this is involving both the white as well as the gray matter, and there is loss of graphite differentiation. So this is an infarct, and usually it is not causing midline shift, but it can, and sometimes we do go and operate the infarcts, ischemic infarcts as well, when they produce significant cytotoxic edema, and we have to go and decompress the patient. Now here you can see there is a hypotenuse area again in the same, nearly in the same location, and you can see the finger-like projections, the vasogenic edema. So there is one difference. Secondly, it is in the white matter, not in the gray matter. And thirdly, there is heightening of the graphite differentiation. So this is how you can differentiate between a tumor, means there is a space occupying lesion, and you can easily differentiate it from the infarct. So I have discussed all the important things, important pathologies which you can identify on the CT scan brain plane. I have discussed about the anatomy as well. I know this is not all the things about the CT scan brain plane, but after seeing these two videos, you will be able to identify all the pathologies which whenever a patient is coming to you from the emergency department with trauma, or with sudden unconsciousness, he has got some kind of infection and they are suspecting some kind of lesion inside the brain, you will be, you will see the CT scan and you will be definitely able to tell that this is abscess, this is infarct, this is hydrocephalus, and then accordingly we are going to manage the patient. I hope that you must have got all the things which I wanted to discuss, and if you have any confusions you can message me. Also you can see the video again, and I want you to uh, let me know if you have any questions, and good luck uh, to you guys. I hope you like this video so that I can continue to make more videos. Thank you very much.